All right. Well, look, we might make a start. Let me share my screen. So this is getting recorded. So anyone that doesn't get the chance to jump on live, we'll be able to see.
How long have you been doing this for?
I've been a podiatrist for 30 years, and my special interest in blisters is about 15.
Yeah.
2008-ish. Yeah, coming up. Yeah.
No, I mean the office hours.
Oh, office hours, probably about a year and a half.
All right, cool.
Yeah. All right, so you can see my slides there?
Yeah.
Rightio. Okay, so, yeah, we're going to be talking about netball blisters, and this kind of stems from an email I got from a podiatrist, and I thought it was a good opportunity to kind of talk about these in more detail. Bear with me. Put that there. Okay, so we're going to have a look at blister incidence. There's a bit of research that tells us about blisters, some popular preventions back in the day and current day. We're going to have a focus on plantar first MPJ blisters and how to effectively manage acute blisters mid-season so people aren't having to miss games and that kind of stuff. And we got some really good questions submitted at the time of registration. So if you have another question or you have your first question, you can either type it in the chat box or put your microphone on and we'll answer them at the end. Okay, so netball is a big blister sport, and it's a big sport in itself. So it's played very popular in Australia, New Zealand, England, not so much America. It's increasing in popularity with men. There's the walking netball now, which is for, you know, I guess our older clients, which is all in an effort to keep people playing netball for longer and avoiding the injuries. And the demands of netball are pretty extreme for the feet and ankles. So netball is a game of 4 15-minute quarters. There's a lot of jumping, acceleration, deceleration, cutting, pivoting. It's really pretty extreme. So, I mean, the games are only an hour, but, man, it's pretty full on for our feet and our ankles and legs. There's a high potential for foot injuries. So let's have a look at some stats. Back in 1986, Hopper looked at foot problems in netball and found that blisters were by far and away the biggest complaint. The others there, if you can't read, are chafing, other, and soreness. Aaron Smythe and team in 2020 looked at the most common injuries requiring medical attention. So from the lowest to the highest here, it's lumbar pain, foot blisters, and lateral ankle sprains. So ankle sprains really common in netball, understandably. And then Kirk and colleagues in 2022 looked at foot and ankle problems reported by male and female netball players in a 12-month period. And so the number of men. Hey guys, do you want to maybe just turn your sound off, your mic off? Just getting a bit of interference. Cheers, thanks. Men was 250, females were 2,220. So the thing to see here is blisters is at the end. So for females, it was the biggest foot and ankle problem that was reported. And for men, it was slightly under ankle sprains. So blisters are right up there in injury for netball. I do know of some unpublished data that suggests there's an association between blisters and subsequent injury, which is not hard to understand because you think about like if you have a plantar forefoot blister, let's say under the first MPJ, you're going to have a pain avoidance gait or movement pattern, yeah? And especially if it's on the medial side, you're going to land and try and get the weight over on the lateral side. So that's certainly going to predispose you to lateral ankle sprains. And we do know that the occurrence of a foot blister is associated with a 50% increased likelihood of musculoskeletal injury. And this was in military recruits. And they were doing things like hiking, walking, running, and just a bit of circuit type stuff. Blister management. These days we have netball specific shoes, which help a lot in terms of just the stability for the foot in the shoe, because there's so much side to side. It's always important to get the right shoe size, optimize that with lacing, break them in gradually. Don't just take them out of the box and wear them. There's a big focus on moisture management. So moisture wicking socks, that people know that they need to keep their feet dry. And back 15 years ago when I started looking at blisters, sanitary pads were used a lot by netballers, and the idea there was a moisture management strategy. I don't see that mentioned as much these days. Definitely all types of padding, taping, lubricants, and more Engo patches. Netballers, probably our biggest customer group for the Engo patches would be ultramarathon runners for a start, then multi-day hikers, and then after that would be netball players. It's such a big blister sport. But there are many, many ways to manage blisters. And if you work to this framework, it kind of helps you make sense of all the options. And we're going to have a little bit of a focus on bone movement today. In terms of the common sites for blister, common blister sites for netball, you'd have to say it'd be the plantar forefoot and the toes. So anything from blisters under the toenail, black toenails, all sorts of toe blisters, particularly under the hallux, and plantar forefoot and the edge of the forefoot and hallux as well, medioplantar edge. There are lots of places you can get blisters. We just tend not to see the heel blisters quite so much for obvious reasons. There's a lot more forefoot stuff. But in this talk, we're going to really focus in on sub-first MPJ blisters. And that's thanks to a question that came in from Cameron. So he had a patient who gets first MPJ blisters only with netball, and he mentioned that she has a slightly plantar flexed or cavus foot, but it's not rigid. So essentially, to me, that means it's like we've got an anterior cavus or forefoot equinus, which is somewhat compensated. So the arch flattens upon weight bearing a little. Now, when I'm faced with plantar forefoot blisters, I'm always looking at understanding what's happening with the bones, how the metatarsals are moving, because you've got to remember that blisters are generated by bone movement in the presence of high friction levels. So generally there's high friction underfoot thanks to weight bearing, and the bones move relative to the skin as a result. So if we have a look at these slides here, so this one is just before the forefoot becomes weight bearing. And then this is as the tibia moves forward, the center of mass is moving forward over the foot, and the arch flattens a bit. So as the forefoot loads more and more, the arch flattens. And this is before the heels even come off the floor. So we've still got a little bit of heel loading as forefoot loading is increasing more and more. So think about the skin surface remaining stationary, but the metatarsal head rolling forward and pushing down. Now, if we add in shear, so this is just the moment before the forefoot becomes weight bearing, the little orange lines there indicate that there's no shear under the soft tissues of the forefoot. And then as the bones move forward, the skin surfaces remain stationary, but the bones have moved forward, and that creates that shear under the first MPJ or under the metatarsal heads. So that's what I'm always thinking about. How are the bones moving? Because with forefoot blisters, there's either a predominance of pressure or bone movement that is relevant to this blister that I need to address. I mean, there's always going to be high pressure under the ball of the foot, but there are reasons why that pressure would be even more than it kind of needs to be or what it would be on average. And those circumstances would be feet that have rigidity to them. So there's a rigid plantar flexed first ray, there's an uncompensated forefoot valgus, or a rigid forefoot equinus. So it's not going to be so much bone movement, but more pressure that we're going to have to reduce. And then there are the people with the things like compensated forefoot valgus, flexible forefoot equinus, which is, I think, what our patients got in this case study, flexible flat foot deformity, ligamentous laxity, functional hallux limitus. These are all instances where the bones are rolling back and forth over that plantar skin. So Cameron's interventions were a soft form ptotic, deflective padding under the device, and an Engo patch on top. Sounds reasonable. So what he's done is these three things. The orthotic is taking care of bone movement. We've got pressure deflective padding, and we've got the Engo patch. So looks pretty reasonable. However, Cameron said that the first MPJ blisters have improved, but are now getting a blister at the distal medial longitudinal arch. So just troubleshooting that. My thoughts are the pressure deflective padding, is this impeding windlass function? So, you know, when you've got the single wing and we've got that bit of padding that is under the distal metatarsal head and shaft, that's essentially, those sorts of paddings, they actually impede windlass function. So if you think that that's relevant to this blister, it might be worth doing something different to avoid that, because essentially we are increasing pressure there. So we're increasing pressure under the distal MLA, and we're also impeding windlass function, which may be counterproductive. Cameron thought, should the coverage of the Engo patch be larger? Now, Cameron mentioned that he likes to use just the minimum of stuff that needs to be used. So he just had he cut like an Engo patch down. So it just was this little Engo patch in the divot or the deflected part. And we know that for adequate coverage, we need about 1 centimetre on all sides of the blister area to provide adequate coverage. And that's before we start thinking about this extreme bone movement. So if the bones are moving backward and forward, side to side with all the pivoting and cutting, you may even need a little bit more. And with netball is a game where I would err on the side of providing more rather than less coverage. But Cameron is spot on in that it can be tricky to use Engo patches with deflective padding. The reason for that is Engo patches don't stretch. They're not like a fix-em-all type of thing. They're more like a rigid tape, you know, one that doesn't stretch. So when you put an Engo patch and you've got deflection, so on like 2 or 3 or 4 sides with the divot in the middle, the Engo patch, it might sink down into that a little bit, but it will make it pucker around the edge of the patch, and that will become an irritant. So it is tricky to use these Engo patches with pressure deflection. Cameron said, I'm not sure whether I should have tried to let her skin adapt to the new friction, because currently this is not a chronic blister. So this was at the start of the season. My thoughts on this are, too often in the past, we've just use this as a cover-up for our lack of understanding of what we can do with blisters in terms of prevention and the relief that we can provide. So I don't think it's ideal to allow people to get blisters and tell them that it's okay and it's for their own good. If you kind of draw a parallel to tendonitis, if someone's got Achilles tendinopathy, we know it's good to load tendinopathy, just like we know that it's good to load the skin in the lead up to, you know, the season starting. It toughens the skin. Yeah, the skin gets more resistant to shear deformation. But you know, if someone after game 2 came to you and had Achilles tendinopathy, you wouldn't say, oh, it's actually good to load tendinopathy, so you'll be right. Just see how you go, should be all right. You would also, at least for the games, you might have an exercise program on the side, but you, at least for the games, you would deload it. So you would deload it so it's less painful so that they could get through the game. Well, it's the same thing with blisters. I don't see why it would be any different. Presumably, this person has either missed the opportunity to train the skin to be able to handle the loads in pre-season, or they have actually maximized it And I feel like there's a lot of people that, you know, you can put those loads on the skin and it will toughen to a degree, but it won't always be enough. And I don't think that it's kind of, I just get disappointed for people who, you know, people in the podiatrists and whatever in the past have said, oh, you just haven't like put the miles in your feet and, you know, you need to train better and whatever. So yeah, get in there and do something, because it's not hard to give really significant relief, even with a blister courtside, so they can get back on and keep playing. So my thoughts on treatment, based on my limited knowledge of this patient, would be some sort of orthotic device, but I'd be, instead of just, you know, looking for pronatory control, if you like, or trying to improve foot function and windlass function, I'd be looking for something more back at the heel, so like a medial heel skive. I'd be thinking, so that I could maximize the friction reduction of ango patches, I would do a forefoot extension 2 to 5 rather than have the deflection come under the first met head, or the proximal, the distal shaft. That would allow me to put an ango patch right up at the first ray, so we had full coverage there. And also Spenco cover. Spenco cover is a great idea if there's no cushioning, no shear absorption in the insole or in the orthotic itself. So I don't know much about soft form orthotics, but I use the red hard form orthotics, and there's really no shear absorption there at all. So you could maybe consider putting a Spenco cover over it, or on your orthotic put a Spenco cover. I use a lot of Interpods, the full length soft ones, because they're a really good combination of cushiness, which is great. People tend to like it, especially with jumpy type sports, and really good support, particularly proximally. And also the cushiness of the material will undergo some sort of shear deformation, which means there's less shear deformation that has to happen in the foot, in the skin. So that's what I'd be looking to do with the orthotic. I'd have a big ango patch extending as far as I thought necessary, and probably a little bit more. So I might even use a rectangle patch cut in half. I'd extend that to the hallux if there's any callousing, even if there's no blisters there, or just put the oval ango patch there. And I'd be looking to try and deload the forefoot a bit. So I'd be making sure we had a decent heel height differential on the shoe, heel lifts, calf stretches if they're tight, which lots of kids are when they're playing netball, and taping. Taping once the skin is able to handle tape, depending on the status of the blister. So that would cover all of those bases. So I feel like we wouldn't need to really go here, although let's say we might reduce our loads during the next training if need be, but essentially my aim is to not have to impact anything here. We've assumed that we've either missed the opportunity or we've maximized the training of the skin to handle the load, the toughening of the skin, and we've taken care of all of this with our orthotic, ango patch, extension 2 to 5, taping, and the material of the orthotic under the forefoot, so Spenco cover or whatever. Does that make sense? Now, the other thing Cameron asked was, what's the best method to relieve these first MPJ blisters? Well, the best way is to implement the prevention while you're doing the treatment. So treatment should not just be first aid. First aid is betadine and a Band-Aid. That's the absolute minimum that we should be doing. It's important to protect that weakened skin and that open skin if it is open, and important to prevent infection. But if you really want this blister to not get worse, even though we've got to keep playing, and to feel a lot less painful, you've got to do something that negates the blister causing shear, and that's what the blister prevention strategy is. So it's basically everything we've just talked about plus the first aid. That's what meaningful blister treatment is, the type of treatment that's going to mean that the person can keep playing without the pain. Okay, that's that. Q&A. Aileen kicks it off with, does deflective felt padding help to prevent blisters? Yes, it does. It reduces pressure, and reducing pressure is a way of reducing friction force. So if we look at the friction equation, friction is the coefficient of friction times the normal force. So it's basically pressure times the coefficient of friction, which is basically a descriptor of a pair of materials and how they interact with one another, how slippery or sticky they are together. So both using materials to change the coefficient of friction, which is what we're doing with the Engo patches. So we're turning the insole sock interface into an Engo sock interface. We're allowing things to be more slippery, and that allows the skin to move in sync with the bone at an earlier moment with each individual shear distortion. And it's the same thing with pressure. If we can reduce pressure, the more things are pressed together, the more force, movement force we need to actually get them to move relative to one another. So if we reduce pressure, we're allowing that slippage to occur earlier. In terms of how much can we expect to reduce pressure with different levels of felt padding thickness, this is what the research shows. So 5 mil gives us 24 to 31% reduction in peak pressure. 7 mil gives us 25% reduction. There was another study I don't have here that showed that 7 mil worked better than 5 mil, which is unsurprising, but you know, you wouldn't say it so with just these two studies here. And then 20 mil, this was in a diabetic population, reduced pressure by 49%. Good question. Leigh asks, basic pre-match management to prevent a blister at a previous blister site. So the important thing here is we understand what the blister site is. And that's really important because each blister location requires a bit of a different strategy because the bones are moving differently for different reasons. But basic pre-match management, I guess you could say having the right shoes and optimizing fit with the lacing. Taping's pretty basic and used quite commonly. Cushioned socks would be a pretty basic thing that you could change if someone's using crappy socks. We know that thick, dense padding is better when it's compared to thick, dense padding in cotton. So that was the Ritchie study. The densely padded acrylic socks, which is synthetic, works better than the cotton. And Spenko insoles would be an easy change to make as well. We sell the 3 mil Spenko insoles on blister prevention. They're really good if the insole is worn, if it's flimsy to start with, and you're not implementing any type of orthotic. But, I mean, who's interested in basic pre-match management? Not me. I'm interested in the best pre-match management, and particularly in a consultation scenario. So I'd be looking to really hone in on that blister site and figure out all the causative factors, get into the mechanics of it, that is the bone movement, plus all the other stuff. But if you're looking for a quick win, if I could only take 2 things to a netball game or a running event or whatever I was going to, they would be Engo patches and gel toe protectors. So Engo patches just reduce friction better than I think everything else, particularly because it does so in the long term. It doesn't impact on shoe fit, and you don't need to reapply it. So they last for, 500 Ks. And the gel toe protectors are great for absorbing shear. No other product does it better than the gel materials, and they're good for the majority of toe blisters, maybe not under the big toe because the gel wears out too quick, but in that case you could put an Engo patch. So if you're looking for quick wins, and if you just want to take a minimum of stuff as well as betadine and a Band-Aid, then I'd take these 2 products. I'd hate to think that there are podiatrists going to sporting events with, the basic stuff like betadine, Band-Aid, taping. There's so much better that we can do. So depending on your level of involvement, and anyone can do betadine, Band-Aid, taping, that kind of stuff. It's time to get serious with blisters. Simone asks, how to avoid blisters in netballers? Well, I find it better to approach this question, how to avoid blisters at X anatomical location, because the best prevention for X anatomical location is going to be the same in netballers, footballers, walkers, runners, boxers, whatever. And then nuance it for the activity. That's the best way to go. Now, how do we do that? So the blister site, how are we going to know what blister sites to attack or to put our focus on? Well, we use our blister history. So the most likely blister you'll get is the one you've had before. This is valuable blister intel. So the patient will tell you this. It's dead easy. Too often we have a blister history and we ignore it. We hope for the best. And it's like, you know, policemen not using all the material they've got available to them to catch the crook. So you've got the blister history, use it to your advantage. As well as that, calluses, anywhere you've got a callus is likely to blister if you increase activity all of a sudden. Calluses and blisters are caused by the same forces, that is repetitive shear deformation. Calluses are the chronic manifestation, blisters are the acute manifestation. So calluses are a sign that just in your ordinary day-to-day, that area is undergoing repetitive shear deformation. And if you increase your activity all of a sudden, it's going to get a blister. And then in a consultation scenario, you could look at any structural or functional issues that might predispose to blisters in certain locations. So that's how we hone in on the location. And then we use our understanding of how blister preventions work. On that again. To get the best prevention or preventions to use for that anatomical location and get them in place before you even start. So don't wait for the hotspot stage, just get them in there, and that way you can take blisters out of the equation, job done. Now, and then we're going to nuance it for the activity. So if we're thinking about netball in particular, the thing that we choose might be a little bit different depending on whether it's a single game or whether it's a carnival. I don't think position would differ much, but you know, if you're indoors, outdoors, depending on the weather, Engo patches might get wet, they might come off. That would be like, what are you going to use for friction management then? Maybe you'll choose Armour Skin socks or some lubricant. So then you nuance it for the activity, but start at the top by understanding the blister site and get the best prevention in place. The other part to Simone's question was, what do we do for acute management? Essentially, it's just like we explained previously for Cameron's case study. Definitely do the first aid. That's the bare minimum that we need to do, but you've got to implement the prevention, because the prevention is the thing that takes away the blister causing forces and stops that blister from getting worse and takes the pain out of it, gives it healing momentum. So they're going to be able to put their shoe back on and keep playing. That's what meaningful blister treatment is. Anything less than that is first aid. This is a bit of this is a handout actually. I'm going to show you where you can get this and you can print it off and give it to your patients. I'm just going to run through it quickly. This explains how we deal with blisters. So the idea is we start and we finish blister free. The best chance that you've got of doing that is by predicting your blister locations and having the best prevention in place before you even start the game. If you don't do that, then your last chance for prevention is the hotspot stage. The problem with this is people and ah, and they think, oh, it'd be right. And then all of a sudden they feel the sting and they take the shoe off. There's no blister there. They think they're safe. They implement the prevention, but a blister is on its way. So you've basically missed the opportunity. And, you know, in the thick of the game, it's going to be hard to come off, you know. Hotspots don't necessarily last that long. Sorry. Then if we don't do enough to stop this blister at the hotspot stage, you'll end up with a blister with his roof intact. Essentially, he just needs a Band-Aid to protect that blister, that weakened skin. It's lost its structural support from underneath. I won't talk about whether or not to lance a blister. That's a whole different conversation. But the gist of it is basically protect that skin, implement the prevention so this blister doesn't go any further and so it stops hurting. If you don't do enough here, then you're going to end up here with a blister with a torn roof. So now it's open to infection. You've got to add the betadine or the antiseptic basically to prevent infection, plus implement the prevention here so that you stop the blister from hurting and stop it from getting worse. If you don't do enough here, then you end up with a de-roof blister, and a de-roof blister, you can do the exact same thing as you did for a torn blister, or you can put a hydrocolloid on this one. Now, hydrocolloids are dressings that aren't for blister prevention, they're for blister treatment. They're like a wound dressing, okay? They're designed to stay on for, 24 hours at least. It's a bit of a waste to be changing hydrocolloids any more frequently than that. A lot of times I see people put a hydrocolloid on and think job done, treatment, prevention, but of course it doesn't reduce the blister causing forces enough. And so an hour or two later, you have to change that hydrocolloid. If that's the case, you might as well just keep going with the Band-Aid instead. And then once the activity has finished, then implement your hydrocolloid. But, really, you could put a hydrocolloid on this mid-game. But if you implement a really good prevention, then that hydrocolloid can still be in place for another 24 hours because you've negated the blister causing shear, so that there's no need for that blister to get worse. Make sense? Okay, Anthony asked, short-term assistance for painful blisters permitting sufferer to continue activities. Kind of the same thing, really. We want to implement first aid to prevent infection, to protect the injured and weakened skin, but it's not going to reduce pain. So to reduce pain, we've got to implement the best prevention for that site. Because the prevention is the thing that negates the blister causing shear, and that's what takes the pain out of the blister and stops it from worsening. Remember our blister treatment equation. Meaningful blister treatment is first aid plus blister prevention. Tamara asked how to myth bust the old thinking that friction is the cause. This is a great question. The problem is friction has two meanings and they kind of mean opposite things. And most of us, when we talk about blisters, we have the rubbing definition of friction. But it's actually the other definition, the more scientific definition that we should be using when we talk about friction blisters, and that is the force that resists the relative movement of one surface across another. The best way that I've found is generally when I'm talking to patients about blisters, I have them on the chair in front of me. I've got their feet right there, and on the dorsum of their foot, I say, most people think blisters are caused by this, but they're actually caused by that. And I'm keeping my finger stuck to that same bit of skin. So all of a sudden, they think, oh, that's kind of the same, but it's different. And they can feel the difference. They can feel the stretching in the skin and the soft tissues. And they're thinking, well, yeah, maybe there's a different angle I can be coming at this from, and that's the start of it. So it is a tough one, but that's the best way I've found to get people thinking a little bit differently. If you could also, if you've got your patient there, you could put some tape on the top of their foot, do the same thing, and you'll see that having the tape there, it doesn't get rid of the blister causing shear, that you'll still feel shear in the soft tissues on the back of the hand or the dorsum of the foot. So in that way, taping is not the be all and end all of blister prevention. So there's different things that we can move on to. Beth asked, what's the best thing to use for long walks? Again, Beth, we would start not with the activity, which is the long walks. We would start with the blister site, and we would know about that because we'd ask about blister history, would look for calluses and have a look at their foot structure and function. Then we would choose the best preventions for that location, that anatomical location, and then we would nuance it for the activity. So is this like a 15K walk on one day, or is this walking 30 days on the Camino? Or what's the weather going to be like? Are we going to have waterlogging? That's going to affect whether we can use adhesive products, that kind of thing. And what are we going to be carrying with us, or can we carry anything with us? Generally with long walks or multi-day walks, we've got a backpack, so we have the opportunity to carry stuff with us. But some people want to pack ultra light, understandably. Well, the best thing about that is put your preventions in place before you even start, and you're not having to carry anything extra. So not only will you need less dressings and the like, but you won't need to be carrying all the stuff because you have it in your shoe already. Really important to get anatomically specific about blisters. Just don't think what's the best thing for netball, what's the best thing for long walks, what's the best thing for football. Think about the anatomical location. Start there, nuance for the activity. Leonie asked, are double socks or tape and socks best to reduce blisters? Tough one. Can't tell you. I can tell you about what the research says. It's equivocal for double socks. There are 3 studies and they all find different things. It's heavily impacted by the different materials that have been used in those double sock combinations, and they were done some time ago. But no, we can't. There's no research we can hang our hat on. Tape, we only have research, 2 pieces of research, and that was for paper tape. And I dare say there's very few of us that use paper tape as a blister prevention. One found that it made blisters worse. One found that it made them better. And socks, we do know that densely padded socks are better than thin socks. So I don't know if that helps. If we think about how the blister preventions work, double socks do this. They reduce the coefficient of friction. What was the other one? Compared to tape and socks. Well, let's assume padded socks. So tape spreads shear load. So it kind of spreads it over a larger area, thereby reducing it per unit area. And our thick socks will absorb a bit of shear. They'll reduce a bit of pressure, and assuming they're moisture wicking or synthetic, they'll reduce the coefficient of friction via moisture management. So if you think about it that way, probably the latter would help more. And theoretically, I wanted to mention that my thoughts on tape is that a rigid tape is probably going to work better than a flexible tape. But that's just my opinion. Yeah, tough one to answer. Do you recommend armor skin blister prevention socks for sports like netball or football? I do, but I prefer a targeted approach. See, the thing with friction is friction's not bad. Friction's actually good where we can get away with it because it provides traction for our foot in our shoe. So the aim isn't just to reduce friction everywhere. I often will go a bit over the top with netball just because there's so much pressure on the ball or the foot, and I can reduce friction not just by pressure management but by coefficient of friction. So I'm looking to reduce the coefficient of friction somehow, and that's how armor skin socks work. But I don't really, especially for side-to-side sports, I don't really want to provide less traction in the shoe. I only want to reduce that friction where it's necessary, which is where we're getting blisters. Hope that makes sense. Okay, we've gone a bit over. Thanks for sticking with me. So we've had a look at blister incidents in netballers, some popular preventions. We've had a close look at first MPJ blisters. I hope that that was helpful in some way. And we've had a look at mid-season acute management. And thank you again for your questions. Now, are there any other questions? Do you want to either type them in the chat box? There's nothing in the chat box. Or turn your mic on and ask, and I'll be happy to answer.
I just have a question, Rebecca. When you said about taping to the first in Callum's case study and using a rigid tape, where do you put the tape on the first MPJ?
If you've got if the blister site is the first MPJ, well, generally we would tape the whole forefoot, but you could just tape the first MPJ. The thing is, it's spreading shear load. So the larger the area you put it on, the more you're reducing that shear load per unit area. So yeah, that's more go large rather than small.
So like low dye taping?
No, for taping, oh, I see what you're saying. So it depends. Are you taping to spread the shear load, or are you taping to have a mechanical intervention to stop the arch flattening?
Yeah, right. Okay. So taping for shear load.
Shear load spreading. That's how we generally do it.
So would you do that as well as the Enyo patch?
Engo patch? Ideally, or not ideally, but usually, no, you don't need it. But sometimes it can be a bit of a mindset change for your patient. They can't understand how it's not a good idea to have something on the skin, something stuck to the skin. So I like everything to settle. Sure, go with the taping as well. And then as things go on and everything's fully resolved, try without the taping in your training. And then they'll get the confidence that, yeah, I don't actually need to tape the skin. But if you're needing to throw the kitchen sink at it, it is an extra mechanism that I would make use of.
Okay, thank you.
But I find that using the Engo patch will do the lion's share of the job. And then if you can manage the bone movement, that's generally it.
Thank you.
Welcome. On Point Podiatry. Next time, using a live foot to tape and offload mechanics and blister short-term management would be awesome. Okay. All right. Any other questions? All right, guys. Well, again, thanks for sticking with me. Feel free to tune in next month. I don't know what we're going to do yet, but it'll be something. And if you want to get that handout, I said that I'll show you where to get that. If you go to pro.blisterprevention.com and head over to the free CPD, that free CPD is a replay of a taping webinar that I did. And it shows you all the ins and outs of taping for blister prevention. And in there, you can download that handout, print it out, give it to your patients. And don't stop at the free CPD. Go on to do the Blister Prevention University, because that's where I talk about every anatomical location, like I did for the first MPJ. I go through all the ins and outs, and also for every blister prevention strategy, I give you the mechanism of action, its pros and cons, and the whole works. So if you really want to get full on into blisters, that's kind of info that you might need, and I'm happy to help. Thanks, guys. Thanks for joining me. See you next month, first Wednesday of the month, and yeah, have a good one. Bye now.